All right, welcome to This Explainer. Today, we're diving into a topic that literally keeps practice managers and clinicians up at night, why your Modifier 25 claims are under intense attack, and exactly how to protect your practice's hard-earned revenue. If you bill for healthcare services, you already know that slapping a Modifier 25 on a claim is kind of like painting a giant bullseye on your back. So, we're going to break down the exact strategies you need to defend your documentation, satisfy the auditors, and keep the money you rightfully earned.
Take a look at this number, 35%. Now, this isn't just a random guess. According to a landmark report from the HHS Office of Inspector General, 35% represents the massive failure rate of Modifier -25 claims meeting Medicare requirements in a single year. Think about that. Over a third of these claims just flat out failed the test. And because federal and private healthcare carriers know this, they absolutely haven't relaxed their scrutiny. In fact, they're ramping it up. This one statistic proves exactly why you're such a target when you use this code.
Here is our roadmap for today. Number 1, the Modifier -25 target. 2, AI enters the audit. 3, what auditors actually want. And 4, winning the documentation game.
Let's just jump right into Section 1, the Modifier 25 target. We need to establish the baseline reality of healthcare audits.
So the core rule for your coders and clinicians is pretty straightforward, right? Modifier 25 allows you to get paid for an evaluation and management, or EMM, service on the exact same day as a procedure. But really zero in on those words. It absolutely must be a significant, separately identifiable service. The big problem we see is that providers do the work, but their notes just kind of blend the evaluation right into the procedure itself. When that happens, the payer just sees one big bundled service and boom, they reject the extra EMM charge. Corella Lumpkins, an expert in coding and compliance, hits the nail on the head here. She points out that auditors are heavily biased against you right out of the gate. Because they so frequently see notes that only reflect work integral to the global surgery period, they're basically pre-conditioned to doubt you. They know improper use of Modifier 25 is a massive source of overpayments. So the reality is, when your chart lands on their desk, their default assumption is that your modifier isn't supported. You're essentially guilty until your documentation proves you innocent. Which brings us to Section 2, AI enters the audit. Let's see how machines are seriously amplifying this risk.
You know, back in the day, you were kind of just hoping a human didn't happen to randomly pull your chart. Well, those days are gone. Machines are doing the heavy lifting now. Step 1, AI continuously monitors your claim frequency and coding patterns. Step 2, it scans your documentation at lightning speed, checking your entire practice's history. And Step 3, once it finds a pattern, it passes those flagged providers over to the human auditors for action. And that action can range from forced education all the way to massive recoupments or even legal action. The AI is the ultimate gatekeeper, and it never sleeps.
I really want you to mentally check your own charts against these red flags right now. Payers are using AI specifically to hunt for repetition. If your frequency of using Modifier 25 is well above average, the AI sees it. If you routinely pair it with CPT code 99214, a higher level visit code, the AI flags it. If you use identical diagnoses for both the evaluation and the procedure, or if you rely on clone notes, templated assessments, and identical phrases across multiple patients, the computer catches that instantly. AI is hunting for this exact kind of repetition because to a payer, a copy-pasted note is a huge flashing sign that the extra service wasn't medically necessary.
All right, Section 3, what auditors actually want. We really need to start thinking exactly like the people reviewing your charts.
And listen, the severe risk of an AI audit absolutely does not mean you should just stop reporting Modifier 25 and give up on that earned revenue. No way. It just means we have to answer one specific question so you can document with total confidence. What do auditors actually want to see when they review your documentation?
And the solution boils down to 3 words: distinct cognitive work. Auditors are hunting for your brainpower. They want to see independent clinical thinking that is completely, totally separate from the procedure itself. Did you address a distinct problem? Did you perform independent data review? Did you engage in separate risk management? The cognitive effort it takes to evaluate a condition has to be visibly separate from the physical and mental work required to just perform the procedure.
Corella Lumpkins brings up a really dangerous trap here. A lot of coders and providers think, hey, I have 2 different diagnosis codes on the claim, I'm good to go. Actually, scratch that. It doesn't work that way. Having different diagnoses helps, for sure, but relying on the code alone without the narrative of your separate work is never going to put your claim in the clear. The auditor needs the story. The documentation has to explicitly show the additional work you did beyond the procedure.
Let's move into our final section, Section 4, Winning the Documentation Game. This is all about the practical phrasing you need for success.
Kick out this contrast between weak and defensible phrasing. It's pretty eye-opening. If you use a weak phrase like patient is here for the procedure, you are instantly feeding their bias that you only did a procedure. It sinks your claim immediately. But look at the defensible phrasing. This visit is for the separate evaluation for another condition. Or you could even say to manage a separate condition. That phrasing acts like a giant neon sign pointing directly to your separate, distinct work. You're literally telling the auditor exactly what they need to hear.
Here's another one. Say you have a patient in for knee pain treatment. If you simply jot down the weak phrase, knee pain discussed, yeah, that completely fails the test. It just sounds entirely bundled into the knee procedure you're about to do. But explicitly stating that you considered alternative treatment options or that you performed a risk/benefit analysis regarding the procedure, that proves your independent cognitive effort. It shows the distinct mental work you did before deciding to proceed.
Okay, you absolutely have to train your team to avoid these weak procedural wrap-ups. Ending your note with, patient tolerated the procedure well, just screams that this was merely a procedural visit. Instead, you need explicit, action-oriented phrasing. Writing something like, medication regimen review and adjusted mathematically proves to an auditor that separate management occurred. It highlights that you did something distinctly different from the physical procedure itself.
It all comes back to this one crucial point from Lumpkins. If an auditor has to search for it, you've already lost. You have to use this strong, explicit language to make the reviewer's job as easy as possible. If they have to dig through paragraphs of cloned text to figure out if you actually did a separate evaluation, game over. They aren't going to hunt for reasons to pay you. You literally have to hand it to them on a silver platter.
So I want to leave you with a challenge for your very next clinic shift. Tomorrow morning, I want you to pick just one chart where you're billing modifier -25. Read it through the eyes of an auditor. Is your separate cognitive work undeniably obvious, or would a reviewer, whether that's a human or a machine, have to search for it? What is that chart actually saying about your practice? Apply these explicit documentation strategies today, and you can completely outsmart the audit machines.